Good morning. I am Dr. Yogesh, Professor and HOD, Department of Physiology, Sri Chamundeshwari Medical College Hospital and Research Institute, Channapatna. And here we have our lab technician, Mr. Shivlingaya. So we thank him very much because he is going to be the subject for all the other experiments. We are going to learn a lot of things because he has agreed and we can learn all the steps and let us not do any mistakes. Okay, now next we are going to proceed with the clinical examination, starting with the respiratory system. So in all these things, first is it is always good to stand on the right side of the patient. Only there are few things where you can move to the left side. Always you stand on the right of the patient. So let me move to the right side. So all these examination we are going to do under main 4 headings: inspection, palpation, percussion and auscultation. I am going to highlight you the most commonly made mistakes. I am not going to redo the entire thing. Most common mistakes only I am going to highlight. First, let us start with the inspection of the subject. So in inspection, whenever you are examining the anterior chest, the patient position is this. Please sit like this, sir. Hands on the sides. This is the best way for anterior chest. Whenever you are examining the axillary areas, okay, this is the best way for axillary areas. And whenever you are examining the back of the chest, you have to touch the opposite shoulders. So when you do that, what will happen? The scapula will move to the side and we get more exposure of the posterior lung fields. Okay, that is the first thing you have to do. So since now, so it all depends what question you are going to get in the exam. So read the question what you have got. Sometimes if they tell examine the anterior chest, sometimes it may be mentioned respiratory system specifically or cardiovascular system specifically. Sometimes both it will not be there. Okay, ideally just read the question once. So now since we are discussing about the respiratory system, let us continue. In inspection, first thing is the trachea. For the trachea, first we make the subject sit straight, sir. Keep your hands like this. Okay, camera can come please closer. Now, and he should not lift the head up. Just he has to sit straight forward. And now, since we are not supposed to touch the patient, just observe the sternocleidomastoid muscle on both the sides. If any particular muscle is very prominent, let's say left side muscle is prominent, it means trachea has moved to that side and there is no place for the muscle. So the muscle has come forward. So only we see that particular muscle more prominent. That is what we are trying to see in inspection. Okay, what is the sign called? Trail sign. Trail sign. Okay, so we are not touching it. So I will just observe. So see straight. Okay. We should not touch the patient because the patient didn't understand what is straight. I just touched him and made him straight. Okay, just observe the muscle. Observe the muscle on both the sides. Okay, it may be prominent, it may not be prominent. We are going to anyhow confirm in palpation. Okay, that is the inspection of trachea. Next is the apical impulse. For the apical impulse, what you should do is you should always look tangentially. So what is the meaning? Now, for this is the one thing where you can go to the left side of the patient. Okay, let me go to the left side of the patient, and it's always good to just go to the lower, sit down, go to the lower level, and next, now what will happen? The rib cage will come here and it will take a turn like this. Okay, so just imagine we are extending this plane like this and we are looking tangentially. Okay, that is what tangentially means. So what is apical impulse? It is the lowermost and the outermost visible cardiac impulse. Observe around the nipple region. Look for any pulsation. You may see, you may not see. Let's say for example, if you are appreciating some fine pulsation here, one common mistake many of you do is when we ask you to report, you will tell it is present in the fifth intercostal space, half inch medial to mid-clavicular line. How can we count the space? I am not supposed to touch the patient. When you touch the patient, yes, you can count which space it is. In inspection, you are not supposed to touch the patient. How can you do it in fifth intercostal space? Okay, so in inspection, you have to tell apical impulse in relation to the nipple. You can just tell it is below and medial to the nipple if it is visible. If it is not visible also, it is normal, nothing to worry about it. So that is the apical impulse. Okay. Next, the shape of the chest. For shape of the chest, what we do? We have to go behind the patient and view from above. Ideally, what is the normal shape? Normal shape is an ellipse. When you see from the top, you are going to see an ellipse. Sometimes what will happen? The patient may have a barrel-shaped chest. So when you view from the top, you are not going to see an ellipse. You are going to see a big circle like that. So for shape of the chest, it's always good to go behind and see from the top. Okay, so we have covered trachea, apical impulse, shape of the chest. Next is symmetry. For symmetry, again what we are going to do, you are going to observe all the areas. Start from supraclavicular, infraclavicular, mammary and inframammary area. What are you seeing in these areas? Whether both the sides are same or there is any difference. For example, on one particular side, it may have gone inside or it may be protruding out little more on that side. So that's what you are going to see. See all the areas, just see whether they are symmetrical or not. In him, if you see, here there is a slightly looks normal, here it's gone slightly inside in the infraclavicular area. Okay, that thing you are going to learn. What are the diseases associated? You will be learning later. But initially you have to identify what are the differences present here. So similarly, so this is for the symmetry of the chest. Okay, next is movements of the chest. In the movements of the chest, now what I will do? I'll ask the subject, sir, please take deep breaths. Slowly take deep breaths and relax. So when he is doing, same thing. Again, observe all the areas. Always bilateral. Just see whether all the areas are moving equally. Please, you can breathe, sir. Slowly, sir, slowly. Take a deep breath and relax. Relax. So you can see the areas. Normally, everything will move symmetrically. Again, it's going to move. Let's say there is a fibrosis on this particular side. What is going to happen? If you ask the person to take a deep breath, that area may not move at all. Whereas the opposite area, it will be moving nicely. Okay, that is what you are going to see in the movement of the chest in inspection.
Respiratory movements, rate, rhythm and type.
Okay, for the rate, rhythm and type, ideally you have to count when the subject should not be aware that you are counting them. You have to tell your assistant or somebody for count for 1 minute and just see about it. So that is about the common things here. And spine. Spine also is very, very important. For the spine, you have to go behind the patient. Can you please come back? Okay, so once we go behind the patient, look at the spine. Sometimes what will happen? Spine will come down. It may take a turn like that. Okay, and that is the lateral bending of spine, the scoliosis. Or sometimes spine will come and it will take an inner turn like that in kyphosis. So these things becomes very important because always trachea, spine, apical impulse will go together. Okay, if you want me to tell one example, you can come forward. Let's take for example, the trachea is shifted to the left side. Okay, the apical impulse is normally present in the fifth intercostal space in the medial to mid-clavicular line. But here the apical impulse is on the anterior axillary line. What has happened now? The trachea has shifted, the apical impulse was also shifted. What does this mean? Do we think that the heart has, there are possibilities like this? For example, the opposite side of the lung has enlarged and has pushed the entire thing to the opposite side. Or let's take one more example. Trachea is central, whereas apical impulse is moved to the anterior axillary line. What does this mean? Now here the heart may be enlarged. There's a left ventricular enlargement, or let's say both are shifted. We feel that the lung has pushed it, but we never examined the spine at all. That particular patient had a spinal deformity. The spine has moved inside like that. There is no place for the heart, so that entire heart structure with trachea has moved to the left. So in that case, what are we doing? If we have missed the spine, we are diagnosing the patient wrongly. We are diagnosing. So only always the spine, apical impulse, and the trachea. You should always see. Then only decide on the further judgment. What is involved over there? Okay. Next is the movements of the chest. After apical impulse, trachea. For trachea, now again see, one more thing I would like to tell is, all this clinical examination, there are always multiple schools of thought. Okay, so, whenever you examine in one particular style, always there may be a probability that another person can tell, no, this is not the way this has to be done, because this is because of multiple schools of thought. Let us learn one school of thought, and if at all there is a chance that if somebody argues it is wrong, don't bother to argue it. It's okay. This is one idea, but you have to understand the concept behind it. Okay. So when you are examining trachea, what I am going to do is, again there are different methods here. I am going to show two methods. I am going to use my index finger and the ring finger. I am tracing the clavicle to the sternoclavicular joint. One finger and other finger on the other sternoclavicular joint. Now, using my middle finger, I will start palpating the midline structures. Go down and stop there. Okay. So once I stop there, try to see the space between these two fingers and these two fingers. If trachea is central, the space will be almost equal. Let's say if my hand is moved this side. What is happening here? The space is more here. There is absolutely no space at all. It means trachea is deviated to left side. Okay, this is one way of doing. The second way is, after you drag down, try to pass your finger in between the sternocleidomastoid and the trachea. Try to pass your finger just to the side of trachea and just see whether the resistance is uniform on both the sides. Okay, you're not going very behind here, because I have seen many of you start doing like this behind, just next to trachea. Okay, so ideally the resistance is almost same on both the sides. If trachea is deviated to a particular side, what will happen? This side it will be very free for me to pass my finger. On the opposite sides, you can feel more resistance compared to that side. So that shows trachea is deviated to the left side. These are the two common ways of doing examination of trachea. Okay. Next is the apical impulse. Again here, what is the first thing? First, you place your hand on the precordial region. Okay. When you place your entire palm on the precordial region, okay, you may start feeling a small impulse somewhere here. Wherever you are feeling, turn your hand to the ulnar side and place it on that particular space. So when I place like this, I can feel something here. Now I'll try to locate with my one tip of my finger. Once you have done this, don't remove this. With the opposite hand, start counting in which space it is present. How to count? Your suprasternal notch, slightly drag down, your sternal angle, second rib is attached to sternal angle. Go to the second rib, count the space. Second space, third rib, third space, fourth rib, fourth space, fifth rib, fifth space. So this is in the fifth space. So this is the mid-clavicular line. So it is almost on the mid-clavicular line. Okay. Sometimes what will happen, you may not feel at all apical impulse. So in that case, when you are placing it, ask the person to bend a little forward. Bend a little forward. Okay. So you will start feeling the apical impulse. If it is not still felt, feel on the opposite side once. Okay, in some conditions the heart would have rotated to the opposite side in gastrocardial. Okay, so if it is still not felt, then you have to start thinking of different pathologies, all other things. Okay, so this is for the apical impulse. Here again the commonest mistake people do who are doing this, you just directly you place your finger, because examiner is going to ask you. They are going to see the procedure what you are doing. The steps involved is important, not the final diagnosis part. Okay, they are going to see how you are performing. So perform each and every step systematically. Movements of the chest. Here again there are only three things in movements of the chest. Okay, so for the first one is go behind the patient, place your hands in the apical regions like this. So take deep breath, relax, deep breath, relax. So now here what I am seeing is, I am seeing whether my both the hands are moving equally like this. This is the movement I am seeing in the upper regions. I am not seeing any movement like this. I am just seeing like this movement. This is the only movement what is going to happen in the top. Okay. In the front, so keep your hands this way. So what I am going to do is, okay. Now here I am just going to stretch my hand. Okay. In the infra mammary area, I'll just try to spread my fingers and take a pinch of skin like this. Take a deep, turn to the left side. Take a deep breath, relax. Take a deep breath and relax, relax. So I am seeing this movement, whether the chest is equally expanding. Why I took a pinch of skin is so the examiner can also see that it is equally going away and equally coming back. Okay, so please do that. So this is in front, only this is there, because I have seen some of you place your hands like this and try to do. There is nothing like this. Only this one we are going to examine in the front. In the behind. So behind again, so cross your hands. Cross your hands. Now I am going to place my hand below the scapula, infrascapular. Again take a pinch of skin. So take a deep breath. Relax. Take a deep breath and relax. Yes. So this is about the movements. Okay, measurements you already know, you are experts of it, so I am not going to go into the details of that. Vocal fremitus. In vocal fremitus, again, what we are going to do now is, I am going to place my ulnar border in all the areas. Okay, when I place my hand, I am telling the subject to repeat 99. Yes sir, 99.
99, 99, 99, 99.
So if you notice here, what I have done, I have checked infraclavicular, infraclavicular, mammary, mammary. I am always comparing. This is what you should do for all the experiments here. Always you should compare to opposite side. You don't do like supraclavicular, infraclavicular, mammary, inframammary on one side, then go to the opposite side. That is wrong. Always compare on both the sides. That is vocal fremitus. Next is the percussion. So in percussion, you have to know the rules of percussion. Okay, and the finger what is placed on the chest is called pleximeter, and what we are going to percuss, this is called plessar. Movement should happen at the ankle joint, the wrist joint, and not at the elbow joint. Okay, so this is the movement you should see, and the other two fingers should be off the air, because many of you I have seen you are going to place like this. I have seen some of you placing this way also. No, this is the best way of doing it. Okay, place your fingers, only the pleximeter should touch with the plessar. I am going to give 2 taps on my middle phalanx. Again I am doing bilaterally. Again do all the areas. Okay, so starting from supraclavicular, go down like that. But here we have clavicular, additional area. In clavicular, what we are going to do? We are going to do a direct percussion. Okay, we are not using a pleximeter. Directly with plessar, you are directly percussing. So that is about the percussion. Please know the notes of percussion. Normally we are getting a resonant note. Where do you get the dull note? Here normally we are getting cardiac dullness and liver dullness and various pathologies. Know the other notes also. Okay. Next is the auscultation. In auscultation, so next is the auscultation. I have already told you regarding the stethoscope, how to wear everything. Okay. So in auscultation, once you wear your steth, just place the steth in similar all the areas. So take a nice deep breath. Relax slowly. So once again, I am comparing both the sides. You are examining all the areas. The normal breath sound, what you are going to hear is the vesicular breath sound. So in abdominal, many conditions are there, many things are there. Bronchial breath sound is one such thing. Bronchial breath sound, if you place your stick on the trachea, whatever the sound hearing, that sound sounds like bronchial breath sound. Please never examine the trachea directly like that. For you to understand what is vesicular breath sound, what is bronchial breath sound, we have taught you like that. Okay? So you should always examine only the lung fields, not the trachea with the stethoscope. And similarly, you are checking for vocal resonance also. In vocal resonance, what we are going to do? Get the step and ask the person to tell 99. 99?
99, 99, 99, 99,
And you continue. Okay, so that is for vocal resonance, and you are going to see for all the added sounds, adventitious sounds, pleural rub, crepitations, all those things you are going to see. So this is in very short about the respiratory system. Thank you.